All right, so I'll introduce next Dr. Wayne Fuchs. Wayne is in private practice and also at Mount Sinai Hospital in New York. Wayne,
Let me
while you're
share my
getting your slides up, I'll
screen.
also say Wayne has also worked with us a very, very long time. Met him shortly after creating PXE International and has been part of a number of our studies. And we really appreciate especially the service he brings to people with PXE for the eye.
Thank you for that introduction. Let me just do one thing. I do want to join the PXE family and express that I am grief-stricken over the loss of Yoni, and I remember him as brilliant, kind, and if I had one word to really describe him, I would have to say humble as well. So in my talk today, I'd like to discuss how PXE affects the eye. I will try to describe for you the anatomy of the eye, the ocular manifestations of PXE, ways to prevent disease complications, methods for early detection of problems that need to be treated, the diagnostic tools that we use to evaluate patients, how we treat active disease. I'll try to illustrate some of these principles with case presentations along the way and share some thoughts about future approaches. Let us begin with the anatomy of the eye. As you can see from this diagram, the eye may be divided into the front and the back. The cornea is like the crystal of a watch. The light passes through the pupil, through the lens, and then the image is focused on the retina. We think of the retina as being in the back of the eye, but as you can see, the retina wraps around more towards past the equator, actually, and that part of the retina provides the side or peripheral vision. The macula, which is in the center of the retina, provides the detail vision, like reading text or recognizing the features on a person's face. The image then passes through the optic nerve. There are approximately 1 million fibers in this optic nerve. It goes to the brain for interpretation of the image, but 500,000 of those, half of those fibers come from this very small area called the macula in the center of the eye. That's why we consider that the functional center of the eye. This is a detailed cartoon of the cellular layers of the macula. Please note the photoreceptor layer. That's the rods and cones or the receptors. Then you have the retinal pigment epithelium separated from the vascular layer or choroid by this very thin membrane called Bruch's membrane. Bruch's membrane has an elastic containing layer, which makes it important in the pathology of PXE, as we will see in a few minutes. There are many ocular manifestations, of PXE. The most common is peau d'orange, already mentioned, or leopard spots. This disturbance is felt to be a calcified, degenerating Bruch's membrane, which is just beneath the retinal pigment epithelium, as I said, and in front of the choroid. It can be described as a widespread area of mottling of the fundus caused by multiple indistinct yellowish lesions resembling the skin of an orange. I don't like the plucked chicken skin thing either. This is the most common finding in PXE, affecting 96% of patients, and is the most apparent in the first 4 decades of life. It is easily seen in both color and red-free photography. Angioid streaks are bilateral, tapering, irregular lines which radiate from around the optic nerve. They may be circular or circumferential. They could be pigmented, or they may be surrounded by pigment atrophy. These streaks represent breaks in Bruch's membrane, which contains elastic tissue and which becomes fragile due to calcium deposition. They may become complicated by choroidal neovascularization, as seen in this color photograph on the left. One can see the faint angioid streaks in this patient with a central scar. there's some blood, fluid, and some lipid deposition surrounding the fluid. You can see the circumferential or circular angioid streaks in this ICG photo on the right, and you can also see the peau d'orange. This patient had already received 2 laser treatments in the past and had a central scar and presented wondering if additional therapy was indicated. Well, 15 years later, the scar was much larger, and perhaps he would have benefited from laser treatment, although it wasn't offered at the time due to the loss of central vision. This brings us to strategies to prevent vision loss. Well, we recommend an avoidance of smoking, as already mentioned, in patients who have already a risk of accelerated atherosclerosis. We recommend a healthful diet, aerobic exercise to build peak bone mass at an early age to reduce the risk of osteopenia and osteoporosis later on in life, which is another good reason to avoid smoking, which can lead to osteoporosis. Eye protection is important, like wearing sunglasses or protective eyewear, especially when engaging in racket or contact sports, as mild trauma can cause bleeding and loss of vision, which I have seen in several patients. Avoidance of the Valsalva maneuver, which is when you bear down and your face turns red, like with straining at a bowel movement or heavy weightlifting. Avoidance of that has been recommended to reduce the risk of bleeding and subsequent scarring. Early detection is very important to reduce the risk of vision loss. It starts with identification and education of patients at risk. This includes examination of family members for evidence of this recessively inherited disease and education regarding symptoms to look for. It includes regular eye examinations by an IMD and routine review of the Amsler grid, reporting any sudden significant change immediately. We revisit that cartoon of the deep cellular layers of the macula to explain distortion experienced when angioid streaks are complicated by choroidal neovascularization. As I said, the choroidal vessels are underneath Bruch's membrane, separated beneath the pigment epithelium. Bruch's membrane may become calcified and fragile, and if choroidal blood vessels break through Bruch's membrane and grow under the retina, they lift up the tissue layers. When the retina is lifted up by these vessels, which also tend to leak fluid, the receptors are displaced and the image is interpreted as distorted by the brain. Patients are provided with an Amsler grid, and it can also easily be downloaded from the computer. If there's a decrease in acuity or the grid develops distortion or blind spots, patients are asked to report these symptoms immediately. What methods do we employ to evaluate a patient in the office? We routinely begin by checking the visual acuity, which is most important, and the bottom line. The doctor performs a dilated exam looking for signs of choroidal neovascularization. That's different from symptoms, which is what the patient experiences. Signs are what we look for. These include blood, lipid, and fluid. We perform fluorescein angiography, fundus photography, and use optical coherence tomography, or OCT, to evaluate our patients. Here you see a color fundus photo revealing peripapillary angioid streaks and peau d'orange. The red-free black and white photo highlights the streaks and the modeling referred to as peau d'orange. Autofluorescence photography uses a series of filters to bring out certain features. Fluorescein angiography easily demonstrates the streaks and the surrounding atrophy of the retinal pigment epithelium in this case. Indocyanine green angiography can offer certain advantages over fluorescein angiography due to the infrared wavelength used in this modality. It better penetrates the pigment layer and a thin layer of blood. It can also better delineate a hidden area or of occult neovascularization. OCT is an abbreviation for optical coherence tomography. It is an invaluable tool in evaluating patients for evidence of active disease. It takes approximately 100,000 images per second and compiles an image of the retina. Here you see a 52-year-old with angioid streaks, a retinal pigment epithelial change called a reticular change. The vertical high-definition OCT transects these streaks and shows some subretinal fluid and subretinal fibrosis. Here's another OCT of a patient with a large area of subretinal fluid under the center of the macula, which we call the fovea. This increased central retinal thickness is color-coded for ease of evaluation and also documented quantitatively for future comparison. This brings us to treatment. Laser was the treatment of choice for new vessels that were not in the center of the eye prior to the advent of anti-VEGF or anti-vascular endothelial growth factor injections. The cold laser or photodynamic therapy has also played a role, but merely slowed the rate of vision loss. Most of the data from anti-vascular endothelial growth factor injections or anti-VEGF injections is extrapolated from our studies on macular degeneration, patients who have a similar pathology. We've used several different medications to inject. Originally, Macugen was used. That was the first anti-VEGF approved. Again, like PDT, only slowed vision loss. Avastin was approved in 2004 for colorectal cancer and has been used in the eye since about 2006, when Lucentis was approved by the FDA. Eylea was approved 5 years later, and we'll talk about them in the question and answer. People may ask about the differences. Beovu was approved about 3 years ago, Vabysmo 1 year ago, and some biosimilars have recently been approved for use since the patent on Lucentis is over. We've studied oral phosphate binders and magnesium supplements, none of which showed a statistical significance, but a trend was shown in decreased calcification and mineralization of tissues. In our patients with severe disease, a referral to a low vision specialist is a valuable tool in the management of PXE. This is an example of a patient who did well with laser treatment. The retinal hemorrhages are seen several millimeters from the fovea. The choroidal neovascularization, or CNV, is lighting up on fluorescein angiography. After red and green laser, this has scarred down and vision returned to 20/60. However, you can see an area of new leakage just superior, just above the initial presentation site. This 48-year-old artist participated in the phosphate binder trial. 1 year after the study was completed, she noted decreased vision in the right eye. Note the hemorrhage near the fovea and the subretinal fluid seen on the old Stratus OCT. The hemorrhage was more apparent on the red-free photograph right here. This was in July of 2006, several weeks after Lucentis was approved by the FDA. After 3 injections of Lucentis, vision returned to 20/25, and this is how the patient looked. This color photo on the right. You can see the angioid streaks, the choroidal nevus, and the absence of hemorrhage. This 49-year-old web designer was noted to have a hemorrhage just nasal to the fovea on her 12-month visit during the magnesium trial. OCT revealed a central scar as well as fluid nasal, temporal, and superior to the scar. She had been diagnosed by neck biopsy at age 16 after trauma to her right eye which occurred during a judo competition, resulting in a hemorrhage, hospitalization, and vision loss. Here are several other deep retinal hemorrhages that she experienced over the years adjacent to angioid streaks. This is an OCT angiogram without injecting dye, showing the choroidal neovascularization and the vascularization on the OCT image. So we don't have to inject dye in most patients these days. 6 years ago, she presented with decreased vision in the other eye with retinal hemorrhages, cystic and subretinal fluid. You could see the fluid under the retina and some cystic change. And she responded to an anti-VEGF injection with reduction of fluid on this high-definition OCT. 9 years after initial treatments were started, she's had 29 injections in the right eye and maintains 20/50 vision, and 18 injections in the left eye with 20/30 vision. The future looks bright for treatment of the ocular complications of PXE. We can look forward to better therapeutics, including longer-lasting agents and improved delivery systems. We continue to explore new therapeutics like TNAP inhibitors and enzyme replacement therapy. There are currently stem cell trials underway, as well as scientists studying transplantation of the pigment epithelium. The ultimate therapy will be some form of gene therapy to truly prevent complications from this disease. In summary, I've reviewed the clinical manifestations of PXE in the eye and presented the diagnostic tools with which we identify and evaluate patients at risk for vision loss. I discussed strategies to prevent vision loss, the treatment options, and illustrated some key points with case presentations. Anti-VEGF agents stabilize a majority of patients with choroidal neovascularization. Physicians must treat early with careful follow-up. Patients must be educated about symptoms to report, such as decreased vision, distortion, and blind spots. Physicians must look for signs on exam, which include blood, lipid, and fluid. Better modalities are needed in the future for the prevention and treatment of the ocular complications of PXE. Thank you for your attention. And I'm
Thanks
happy
very
to
much.
take any questions.
Great. Thanks very much, Wayne. So there's one question in the chat. Can you speak to atrophy in the retina? Pam has vision loss due to atrophied cells. And so maybe that would also be in the same category as dry macular degeneration.
So there was a published case from Colombia of someone that lost vision from atrophy. Of course, we see this more frequently now. Since in the very beginning, people lost vision in the very beginning of my experience from hemorrhages, which we now prevent. Fortunately, 90% of the time we stabilize eyes. Since we've been treating with anti-VEGF agents and drying certain patients, they are maintaining vision longer, and there is progressive atrophy in many cases, and so there can be loss of central vision from atrophy without any neovascularization. We currently do not have any treatment for atrophy. However, the good news is that there are actually two drugs that are, I used to say we will have something in the near future, maybe in 3 to 7 years. And now I can say maybe in the next few months, because some of these agents are being fast-tracked by the FDA since there is no good treatment. And one is made by a company called Apellis. Let me see. They don't really name the drugs until they're approved by the FDA. Another by a company called Iveric Bio. And there is some talk about a meeting by the FDA as early as next month in February to discuss approval based on some phase 3 data. So no guarantee. We don't know what the FDA is ever going to do, but these medications would slow the progression of atrophy. They don't reverse atrophy. That's why I alluded to stem cells in my talk and retinal pigment transplants. But In those patients who have lost vision to atrophy in one eye and experiencing progressive atrophy in the second eye, they would certainly welcome a drug to slow the progression of atrophy. These would probably be an injection in the eye, like our anti-VEGF injections. And it would probably be every 2 months based on the protocol that was studied in phase 3 trials. But so something to look forward to, not reversing vision loss, but to slow the progression.
Great, thanks. And we have a bunch of questions, Wayne, so I'm going to have to ask you to have brief answers.
Brief answer.
So, so is it common for PXEers to have higher difficulty driving at night and trouble with the lights coming at them? I should say, Marta, to the questioner, tomorrow, Christina Fau, who's studying this, will be speaking in the research section. But Wayne, your experience?
All right, so people as they get older with PXE, macular degeneration, other diseases like glaucoma, certainly cataracts have more trouble at night when there's reduced contrast. And yes, we see that. And of course, there's not much to do. We ask people to avoid driving at night if they're insecure. You could have difficulty from glare from oncoming headlights, and it's a good idea to suspend night driving in that case. We don't have a treatment for that.
Does PXE or the injections cause an increase in eye pressure, as mine are pretty high at 27 or thereabouts and ended up with closed angle glaucoma from one injection, causing instant temporary blindness until the consultant released eye pressure by inserting a needle?
So we inject a very small volume. It's 1/20th of a cc, 1/20th of a milliliter, but that certainly increases the eye pressure immediately until the eye equilibrates. So in people with very high pressure, sometimes it's safe to do take out a little fluid before the injection. That's rarely needed, very rarely needed. That's called a paracentesis. And the other answer is that over time, some patients do have a tendency to have increased pressure after multiple injections, which is usually easily controlled with the eye drops, the drops we use for typical glaucoma. Narrow angle glaucoma is another thing. It's a shallow chamber. It's an anatomic thing, and usually that's if someone has narrow angles, they can have an attack of glaucoma, and usually if the physician is worried about that, a simple procedure called a laser iridotomy, a hole in the iris, can be done by laser. It takes a few minutes. It's an in-office procedure, and that will prevent angle closure.
Great, thank you. Miriam, do you want to unmute? You're next in line.
Okay, so I'm a bit confused as to who is a candidate for the eye injection. Whenever I go to my retinologist, I'm always told that I do not have any bleeding or fluid in my eye. So there's really nothing that they can do for me. But my concern is that are injections helpful to prevent these kinds of conditions? And what is meant by atrophy and as compared to, the bleeding or the fluid in the eye?
Atrophy as compared to, just repeat the last.
Well, the bleeding or fluid.
Okay, so
atrophy. And
atrophy is loss of pigment. That's what we say when we're saying there's atrophy, but the pigment is a complex. We see loss of pigment easily when we're examining someone, but the rods and cones are microscopic in size, and unfortunately the pigment is kind of a complex with those receptors. So when we see loss of pigment, there's also loss of rods and cones and then blind spots. So when we're talking about atrophy, we're talking about loss of pigment, and that's what we call dry, for which we have no treatment, as I mentioned before. There may be treatments available in the near future. When someone is wet, that is, they're either leaking or bleeding, that is when they have new blood vessel growth, and those vessels are incompetent, so they leak fluid. And if that little incompetent spot, that little, whatever it is, you can call it a fenestration or leaks fluid, if that little incompetent spot gets a little bigger, red blood cells can sneak through those vessels. So leakage usually precedes bleeding. And those are the things we look for that, as I mentioned, fluid, blood, and lipid molecules. That is a patient who is active, and we would inject that patient. So yes, we look for fluid, blood, and lipid, and those patients are candidates for injections.
So if you
Okay,
see no leakage, just to make sure I'm clear, so if you see no leakage, then there's no projected benefit from getting injections to prevent anything.
That's correct. I
Okay,
meant to say that, yes.
yeah, okay, thank you.
Wayne, a question from a dad. How long does it approximately take from the onset of angioid streaks to visual impairment? A 13-year-old son.
13-year-old son. So, so we see sometimes impairment of vision in the 30s or 40s in someone that's had streaks at a young age. It takes decades. It's a mystery. Maybe that's the answer that we should look for. Obviously, prevention is the goal here, gene therapy. But if we could figure out why somebody has this streak, this dehiscence, this break in that membrane, and it does take several decades for angiogenesis to kick in. If we knew what was preventing it for those 20 years, that might help us to treat this. But usually several decades is the answer, the short answer, which you asked for.
Right. To what extent is retinal inflammation leading to acute retinopathy seen? And if so, are there ways to prevent it from happening and potential treatments for it?
Well, we recently implicated inflammation in many diseases, including heart disease. We know it plays a role in angiogenesis, and we try actually not to treat eyes that have active inflammation. In fact, one of the drugs I mentioned in the slide with the listing the anti-VEGF drugs was Beovu, brought out by Novartis 3 years ago. We tend not to use that. My apologies to Novartis as a first-line drug because it did cause inflammation in several patients and severe inflammation and vasculitis and rarely an arteriolar occlusion and loss of vision. So inflammation we take quite seriously. We like eyes, we treat aggressively. If someone has inflammation, we would postpone an injection. Of course, we like to treat with injections if we see active neovascularization, but we don't like injections during active inflammation. And it does play a role in neovascularization as well.
Okay, and so would you say that it's common in PXE and you see it quite often, or would you say it's
No, I
not
would say
associated?
uncommon, not common at all to be seeing inflammation.
Okay, a couple
very quickly, if I could say, I'm sorry. What is how is it treated typically?
With topical drops, steroids and anti-inflammatory non-steroidal drops. If it's severe, like in a case where we've given Beovu and the patient has a vasculitis, a systemic medication as well. And you could inject actually a steroid into the eye, which is rarely needed. And we worry about doing that because that can cause cataracts and glaucoma. So we try to avoid that.
Thank you.
Great, thanks. And a couple of Amsler grid questions. What about when you see a distortion on the Amsler grid? How quickly should you go to the retinologist? And then if you see a distortion, could it be a retinal detachment rather than an alteration due to a bleed? And I'm going to just say the person asked, instead of an angioid streaks don't cause alterations in the Amsler grid. It's the fluid that's coming through the angioid streak. So.
Right. So, the answer is promptly. You should call the retina doctor. There are many things that can cause distortion, wrinkles on the retina, scar tissue on the retina. You could have vein occlusion is a common thing. Diabetics have leakage, but if you have angioid streaks and you have what we call a sudden significant change in your vision, you should call the retina doctor and be seen promptly. it's not something you want to be seen Sunday night at 3 a.m. for, but you want to call Monday morning at 7 a.m.
Okay. How about dry eye syndrome? Is it prevalent in people with PXE, and can intensive pulse light treatment be safe for people with PXE?
Dry eye is a very common disease in seniors, and particularly bothersome in cold, windy days, which we're having here in New York today. I don't know that it's more common in PXE patients, and I'm not sure which pulse laser is being referred to, so I'll have to answer that one later privately. We'll give out my email address, and I'll look into whatever laser we're talking about.
Great, thanks, Wayne. And if you're 78 years old and you have no sign of PXE advancing in your eyes in any way, should you still go every 6 months for an eye exam?
I would go once a year at that point.
Okay.
You're golden.
Great. I think I got all the questions in the chat. Yes, I think we did, because there were a couple overlapping ones. All right. So, I want to give people a little break before we go into the next session. So I want to thank you, Wayne, as always, for
Thank you all.
coming to us with all that you have to offer.